Bismillah ar-Rahman ar-Rahim. Dear fourth year students, I am Assistant Prof. Mahdi Arubei. Our lecture today is functional appliances, classification, mode of function, indications, types, advantages, limitations, and other orthopedic appliances that are extraoral traction appliances, space spray gainers, Invisalign or clear aligners. Orthodontic and orthopedics. Usually orthodontic patient, when during his or her diagnosis, there is some question to be asked. That is, does this patient require orthopedic treatment, or a combination of both? This question is usually asked in the treatment planning of many growing patients. Orthodontic treatment means the correction of dental irregularities, but inappropriate for treatment of skeletal discrepancy. On the other hand, orthopedic treatment is the correction of malocclusion primarily related to skeletal disproportion. So, there is a combination of both orthodontic and orthopedic treatment, that is the dentofacial orthopedic treatment. This is a wider definition than orthodontics, aims to treat malocclusion primarily related to musculoskeletal discrepancy. This is by combination of orthodontic treatment of dental irregularity and jaw-to-jaw relationships by correcting the muscle function and restore facial balance. How much orthodontic or orthopedic forces should be applied? Orthodontic appliances are designed to apply light force to move the tooth or group of teeth without stimulating the mandibular growth during treatment. The force is about 28 grams per centimeter square of root surface. More than this amount may lead to root resorption, because the root will not be tolerated to the force. Unlikely, orthopedic force is related to the tolerance of orofacial musculature rather than periodontal ligament. It is directed toward change of position of mandible and correct the relationship of mandible to maxilla. Here, a type of orthopedic appliance that is called the dealer mask or reverse headgear. Functional appliances or myofunctional appliances. These are removable or fixed appliances that either utilize, eliminate, or guide the forces arising from muscle function and altering the position of mandible, causing stretching of the facial soft tissue to produce a combination of dental and skeletal changes. They are most frequently used for correction of anteroposterior jaw relationships in Class 2 malocclusion. However, Class 3 malocclusion can be treated occasionally. Classification of myofunctional appliances. They are classified as tooth-borne, like twin block, or tissue-borne, like Frankel appliance or Frankel regulator. Passive, that carries no active component such as bionator, or active, occasionally carries expansion, screw, and or springs such as twin block. The indications for functional appliances. Usually they are used for mild or moderate Class 2 skeletal discrepancy without mandibular retrognathism. They are also used in a growing patient during pubertal growth spurt, that is, in male about 14 plus minus 2 years and in female about 10 years plus minus 2 for ideal responses. They are also should be used for patients who are with high level of compliance. So they need the cooperation of the patient to tolerate wearing the appliance and attend regular visits to the orthodontic clinic. Mode of action of functional appliances. These appliances correct at least or reduce the anterior jaw relationship in a process known as growth modification or dentofacial orthopedics. This is achieved by forcing the mandible to posture forward, stretching the soft tissue that are muscles of mastication, forcing force transmission. So the force of the muscles of mastication can be transmitted to the teeth via the myofunctional appliances, and also encourage back compensatory growth of mandible. They also increase the lower anterior facial height, especially in people with deep bite, and restraining the maxillary growth. And finally, the resultant correction in overjet is attributed to about 70% tooth movement, so they work on dental units, and about 30% change the mandible form and size. Time of treatment with functional appliances. The suitable time for treatment of functional appliances is pubertal growth spurt. What is the growth spurt? The growth spurt is defined as a period of sudden accelerated growth rate scattered within periods of relative rest. So the people during certain period of their life have an acceleration in velocity of their growth. So we can see that in a certain age, especially in female, at age of 10 to 12, the female, while they can be seen as a child, after 3 months or 4 months, they can be seen as a lady during several months. And the same for the boys, that during several months, this is called the growth spurt. Even the sound will be, the volume of the sound or the voice become much more different. How growth spurt can be predicted? There are three methods for prediction of growth spurt. First of all is by regular measurement of the body height. Secondly, because the growth spurt, if there is an acceleration in the increase in body height, this means that the individual is passing through his or her growth spurt. Secondly, by hand wrist X-ray to estimate the development of the phalanges and radius, because there is certain ossification of phalanges and radius during the pubertal growth spurt. And the third one is by cervical vertebrae visible on lateral radiograph during the period of maximum mandibular growth. Cervical vertebrae C2, C3, and C4 changing the shape from wedge to column, from this shape to the column shape. Can functional appliances be used in childhood earlier than pubertal growth spurt? Yes, they can be used, but there is certain disadvantages. They can be used especially if there is a psychological concern relating to the aesthetic impact of the maxillary incisor prominence, or there is a significant increased risk of trauma due to an increased overjet. So the increased overjet make the people more predisposed to trauma, and as you know that the more prominent anterior teeth make the patient undergoing some teasing and bullying during the school age. However, they appear to have a greater effect on skeletal growth if the treatment takes place during the optimum period for the following reasons. First of all, skeletal growth will be optimized. Second, treatment will be coincide with a late mixed or early permanent dentition. Third, it will allow immediate placement of fixed appliances following functional appliance treatment. And lastly, it will reduce the overall treatment and retention time. Types of functional appliances. The first type is the twin block. The twin block is the most predominantly used functional appliance in the UK. So it is well tolerated by the patient as it is constructed in two parts. The upper and lower parts fit together using posterior bite block. So this is the posterior bite block with interlocking inclined bite plane, which posture the mandible forward. The blocks need to be at least 5 mm high, which prevent the patient from biting one block on the top of the other. Instead, the patient encourages the mandible to move forward so that the lower block occludes in front of the upper block in an angle between 45 to 70 degrees. The appliance can be worn full-time, including during eating in some cases, which means that rapid correction is possible. Here the upper bite block and this is the lower bite block. As we see that it is also possible to modify the appliance to allow expansion of the upper arch by incorporating expansion screw, or maybe by adding an artificial tooth replacement. An alternative modification to allow correction of class 2 div 2 malocclusion is by incorporating Z-spring in the upper part of the upper part to proclaim the incisor and convert the case to class 2 div 1. It is also easy to reactivate the twin block appliance. This means that during treatment, if the further advancement of the mandible is required, it is possible to modify the existing appliance rather than having to construct a new one. But the disadvantage of twin block is one of the side effects of the twin block appliance is the residual posterior lateral open bite. After correction of the overjet and correction of deep bite, there is open bite, posterior open bite. This is seen particularly in case initially presenting with a deep overbite. The posterior teeth are prevented from erupting by occlusal coverage of the bite blocks. Some clinicians may trim the acrylic away from the occlusal surfaces of the upper block to allow the lower molar to erupt. Any remaining lateral open bite are closed down in the fixed appliance phase of treatment after removal of the twin block, after ending the stage of the twin block. The second appliance, functional appliance, is the Anderson activator. The activator was originally described by Anderson and Hoppel in the early 20th century. It was based upon the hypothesis of stimulating increased muscle activity in mandibular elevator and retractor muscles to act directly on dentition through the appliance and stimulate the condyle to allow remodeling and growth. It is a loose-fitted monoblock appliance that advances the mandible with lingual flanges. Occasionally, facets were cut into the acrylic to guide the eruption. Here, some facets are cutted to allow the eruption of mandibular posterior teeth medially and the maxillary posterior teeth distally and buccally. Harvest appliance. The harvest appliance is a fixed functional appliance. The components: there is a section attached, banded or bonded to the upper buccal molar teeth and a section attached to the lower premolar teeth. These sections are joined by a rigid arm that posture the mandible forward. The advantage, as it is fixed appliance, It removes some, but not all, compliance factor and better tolerated than the bulkier functional appliances. But the disadvantage is expensive and increase breakage rate. Bionator. The bionator was originally designed to modify tongue behavior using a heavy wire loop in the palate. The lack of acrylic in the palate make it easy to wear. A buccal extension of the labial bow holds the cheeks out of contact with the buccal segment of the teeth, allowing some arch expansion. Medium opening activator. This is one-piece functional appliance with minimum acrylic to improve patient comfort. Frankel appliance. This appliance is also called Frankel regulator. It is completely tissue-borne appliance. As we see, it is not supported by the teeth. So it is tissue-borne appliance. 4 types of Frankel appliance or functional regulator. Class 2, Div 1 we use Frankel 1. For class 2, Div 2, we use Frankel 2. For class 3, we use Frankel 3. And for anterior correction of anterior open bite malocclusion, the Frankel 4 is used. Appliance is rarely used in contemporary orthodontic treatment because of several disadvantages such as difficulty in wearing and fabrication and is troublesome to repair. Oral screen. It is a curved shield of acrylic centered in the vestibule between the labial and buccal aspect of the teeth from behind and lips and cheeks from the front. Types. Active. It transfers the force of circumoral musculature to the most proclined tooth, while the passive appliance eliminates the force exerted by circumoral musculature and allowing the teeth to move labially by action of the tongue. Advantages. It acts as habit breaker in patients suffering from mouth breathe, tongue thrust, lip and cheek biting that inhibit the thumb from entering the mouth or the tongue from get in between the upper and lower incisors. The second advantage is muscle trainer for hypotonic lip and cheek muscles. So it can be act as muscle trainer and the patient can press against the oral screen and the muscle become exercised. The last advantage is used to retrocline mild proclined anterior teeth. Lip bumper. Lip bumper is a combined removable fixed functional appliance used in both maxilla and mandible to hold the lips away from the teeth, also used to hold the lower molars back while allowing the lower front teeth to move forward. This provides space for overcrowded anterior teeth. The uses of lip bumper in patient exhibit lower lip sucking, in patient with hyperactive mentalis muscle, to support anchorage and to distalize the molars, and finally as a space regainer. Jasper jumper. This is introduced by Jasper 1980s. It is a fixed ortho tooth-borne functional appliance characterized by more flexibility and less rigidity in comparison to Herbst appliance. The disadvantages: it produces continuous force, does not require patient compliance, allows a greater degree of mandibular freedom than Herbst appliance, and oral hygiene is easier to be managed. How to prepare the functional appliance? First of all, as all orthodontic appliances, a good impression should be taken. That is extended, including the vestibules and the teeth. Secondly, bite registration with mandible postured forward, as we see in this figure. Here the patient is a severe class 2 div or mild moderate class 2 div div 1 with the proclined upper anterior teeth, but the mandible during bite registration should be postured forward. So all functional appliances work by posturing the mandible forward. Third, the vertical space between the upper incisor and lower incisor should be about 5 mm separated. Activation of functional appliance. Activation of the functional appliances is achieved either by an incremental advancement of the mandible during the treatment, which may make it easier to tolerate and improving patient compliance, or by fabricating a second appliance once the overjet has been partially reduced. So here in this 20 block, there is some addition of an increment of acrylic between the lower and upper blocks, and then curing of the acrylic. This is acrylic light cure. Insertion and reviewing of the appliance. The appliance should be inserted within 2 weeks after impression taking to ensure good fit and not the impression distorted. Secondly, the review appointment can be made every 6 to 10 weeks interval. At every review appointment, motivation of the patient is vital, as well as checking the fit of the appliance and treatment progress. Third, no wear or poor wear of the appliance can be identified by some sign such as, so if the patient didn't wear the appliance during the last month, this can be discovered by the clinician, by the good clinician. This is by continuous speech problem, because the patient was not tolerated during speech to the appliance because he left the appliance for a long time. Secondly, a fresh and clean appliance with no sign of wear, because wearing of the appliance lead to accumulation of calculus. Though a clean appliance means that the patient didn't wear it. And lastly, numerous breakage due to repeated and removal by the patient. So if the appliance is broken several times, this means that the patient removed it several times. Duration of treatment and retention of functional appliances. It has been suggested that the treatment time should not be less than 12 months, followed by a retention period of the same length, before the commencement of the second phase treatment with the fixed appliance, to close the posterior open bite created due to moving the mandible forward in the new position. So to sum up or to summarize the subject of functional appliance, we should know that the functional appliances are posturing the mandible forward in the growing patients. Secondly, they are used for correction of class 2 skeletal problem. Thirdly, they can be followed by fixed appliance. Fourth, they can be used earlier for psychological reason and to reduce the risk of trauma. 5. They produce 70% dental effect and 30% skeletal effect. 6. They need patient compliance. And 7. They are successful in 70 to 80% of patients. The second half of this lecture is focusing on the other orthopedic appliances that are extraoral traction appliances. The first extraoral traction appliance is the headgear that can be used or added to a fixed appliance or removable appliance or even functional appliance, such as 20 block appliance, usually with the aim of achieving orthopedic changes. The direction of pull of headgear at the time of treatment planning, the direction of pull should be considered, which is one of the following three directions: either high pull headgear or occipital, which helps to restrict the vertical growth of maxilla and reduce overbite, so typically used in cases with increased vertical proportion. Second, low pull headgears, that is cervical headgear, which is used to increase the vertical dimension by having an extrusive effect on molar in cases of reduced vertical proportion. And third one is straight pull headgear which control the anterior posterior and is typically used in cases with average vertical proportion to reduce the overjet. Force magnitude and wearing time of the headgear. The magnitude and duration of the force varying according to the purpose. These appliances usually best achieve the appliances usually best achieved by wearing the at bedtime. The minimum duration of wearing is shown in the table below. For orthodontic purpose, the force applied 400 to 450 gram. For duration of wearing about 12 hours. For orthopedic restraining the maxilla purpose, the force is about 500 gram for 14 hours wearing. While for anchorage, we need to apply 250 gram to 350 for wearing time about 10 hours. Headgear components. First, the face bow, that including the inner bow and outer bow. This is the inner bow and that's the outer bow. Second, head cap or neck strap. This is the neck strap. The springs mechanisms or straps. This element connect the face bow to the head cap or neck strap. And it is supplied with safety release mechanism to protect the patient from injury during the excessive force or accidental pulling out and recoil by other children. So if there is an excessive pulling, this will be dislodged and separated, making the headgear is separated from the inner or outer bow from the face bow and then keeping the patient from injury. Disadvantages of the EOT. Success with intraoral traction is dependent on good patient cooperation. The patient may often not wear the headgear for the prescribed duration. This has led nowadays to reduction in the popularity and the use of the headgear within clinical orthodontic practice. Reverse or protraction headgear or dealer mask. This appliance can achieve skeletal changes by advancement of maxilla and or restrain or redirect the mandible backward. This can be achieved in patients where a face mask is fitted and worn minimum of 14 hours per day prior to pubertal growth spurt before the maxilla stops growing, which is usually at 9 years old. A forward maxillary pull is applied with the help of heavy elastics that are attached to hooks on the rigid framework. Chin cup, an extraoral appliance that fitted by mean of a head cup to occipital region and has attachment for the placement and activation of the chin cup, usually to restrain and redirect the growth of mandible as easy as possible, even in 4 to 5 years old. Space regainer. Up to 3 mm localized space deficiency can be re-established using a simple appliance called space regainer. During mixed dentition, a localized space deficiency may arise due to early loss of the deciduous teeth and drifting of the adjacent teeth toward the space of extracted tooth. It is necessary, if a space maintainer was adequate, to regain the space and return the space discrepancy to zero in order to permanent teeth to erupt in normal position. The space regainers are maxillary space regainers that are removable. Maxillary space regainer, which is a simple removable appliance with a multiple Adami clasps and a finger spring or jack screw to distalize the permanent molar that shifted due to early extraction of deciduous molars. Fixed maxillary space regainer bodily movement of first permanent molar can be performed using fixed space regainer formed from coil spring or U-loop. This is a coil spring or U-loop on segmented arch wire. Mandibular space regainer. It is the removable mandibular space regainer that is less satisfactory than maxillary space regainer because it is fragile and prone to breakage due to loss of palatal anchorage. The fixed mandibular space regainer is formed from either adjustable lingual arch bonded to permanent molar bilaterally against the anchorage offered from incisors, or lip bumper fitted to the tubes on molar. The idea is that the lip bumper press against the lower lip, which create distal force to tip molar posteriorly. The other subject is the Invisalign, that is a proprietary orthodontic technique that uses a series of sequential computer-generated plastic aligner to deliver a course of ortho treatment. The concept was around 1945, however, first Align technology, product of the clear aligner, was computerized in late 1990s. Why aligner became more popular? This is because increased treatment demands by adult. Secondly, increased demands for aesthetic treatment. Third, development in 3D printing technology and direct manufacturing from computer software. And fourth, due to extensive marketing by manufacturers to clinician and patient, leading to increased awareness. Advantage of aligner. First, more aesthetic appliance, improve dental and periodontal health, reduce risk of decalcification, the reduction in chairside time, overall treatment time, pain experience, and root resorption. What is the process of manufacturing the aligner? First, taking impression must be taken with a polyvinyl silicone due to its superior accuracy. Second, submission of patient intraoral and extraoral photographs and radiograph to Align technology in addition to the complete treatment form. This is online application. Third, sending the PVS impression and byte registration are scanned to create accurate 3D digital model. So these are sent to the company, and the company will scan to create accurate 3D digital model. 4. Trained Invisalign computer technician makes a design of series of clear aligner to move the teeth to their final position. And the fifth step is by preliminary plan is submitted to doctor for approval in form of computerized movie view by using Invisalign ClinCheck software. The sixth step is once the plan is approved by the doctor, a payment is completed and a series of casts are created using a stereolithography, and a complete set of clear plastic aligner are sent directly to the doctor. 7th step, each aligner is prescribed to be worn for 2 weeks and is only removed for eating, drinking, brushing, and flossing. Types of tooth movement achieved by aligners. At the beginning, aligners were designed to manage rotated, proclined, retroclined anterior teeth. However, there was little scope for mesiodistal or vertical tooth movement or root torquing. Then after, use of pre-planned plastic attachment, as they are seen in this view, in conjunction with advanced plastic aligner material, enabled more difficult tooth movement that is comparable to the fixed appliance movements to be achieved, such as derotation of the round teeth that are canine and premolar, relative intrusion and extrusion of one or multiple teeth, that means the vertical movement of the teeth, and lastly root torquing. And this is a summary of the tooth movements that can be achieved by the clear aligners. Thank you for listening and have a nice day. Good luck.